Welcome to the JAMA Evidence User's Guide to the Medical Literature podcast. I'm your host, Dr. Gordon Guyatt of McMaster University, where I'm a professor. And today I'm joined by Dr. Mark Wilson, Professor of Medicine at the University of Iowa and Associate Dean there of Medical Education. The scope of evidence-based clinical practice is rapidly evolving, and the settings for evidence-based clinical practice teaching are broadening. This user's guide to the medical literature identifies some related challenges to educators and provides examples of innovative responses. And because of that is why I'm so delighted to have Mark Wilson here. Mark and I have had the good fortune to be working together for over 30 years, I believe. And so I can confidently say, if we don't have the world's best evidence-based clinical practice educator with us, we have somebody who's at least as good as anybody else. So, Mark, thanks very much and welcome.
Great being here, Gordon.
So, why did we need a teacher's guide to the user's guide?
My recollection as this unfolded was the user's guides to the medical literature is such a rich contribution that some might confuse it with a deep encyclopedia, and the opportunities that are embedded within it for clinical teachers are rich. And the intent of this chapter was to be able to share what is in there and how could it be used in different ways by clinical educators.
What training or experience do you think educators need to teach evidence-based clinical practice?
That's a great question that has mystified all of us for years. There's no getting around. There has to be some familiarity with the content. You've heard me say in the past, no one needs to wait for expertise to be able to start integrating explicit clinical research into their teaching. But it does help for them to be an enthusiast, one who's continuing to embrace, if you will, a growth mindset about continuing to learn the clinical epidemiology content, study design, new constructs that are constantly evolving, new concepts that are evolving. So some familiarity with the content is critical and a willingness to continue growing. I think then if that can be coupled with, for those of us that are excited about clinical education, if it can be coupled with that passion for how do we help the next generation of physicians to do better than we did and than we can, how do we help them to grow into stronger physicians through our work? That's then when it becomes magical at that intersection between patient and the clinical learner.
So ideally, if you're teaching about a particular clinical problem, you have to know the evidence, or it's pretty tough to do evidence-based clinical practice teaching unless you know the evidence. You have to perhaps know something about study design and what makes the evidence higher quality or lower quality. And you need to know something about teaching. Have I got that right?
I think so. The other piece I would encourage all of us to keep in mind is we don't have to know the clinical evidence answer to the predicaments that we run into. It's helpful that we've got some in our back pocket, but it also, for example, provides an opportunity to do just in time, if you will, point of care exploration of what's the best evidence to answer this uncertainty that our team is wrestling with as we're trying to care for an individual patient.
I think that's a super point. It would suggest that another thing that it would be good if the educator knows is how to get quickly at the best evidence.
Absolutely. Absolutely.
So that'd be another skill that would be desirable. Okay, great. If it is wise to teach evidence-based clinical practice in clinical settings, how can that occur within our time-pressured patient care areas?
While at any given moment, we tend to think that the current clinical arena is the most stressed it's ever been, but it's always been a challenge throughout all years, certainly throughout my entire career. So one piece is becoming comfortable with we never will have optimal clinical teaching opportunities. And so what's important for us is to be able to identify what are the needs of the learner and the patient, because at that intersection is where there are oftentimes rich opportunities that are going to affect clinical decision making for an individual patient. It's really important for us to also be judicious because we need to, in so many words, bite off less than we can chew. So to be very careful in how much we try to interject into all the different clinical capabilities that our learners need. How do we choose judiciously when and how to insert an aspect of evidence-based clinical practice? I'll have to tell you that one of the humbling things that happened to me as a program director who was very enthusiastic about the challenge of this very issue was that an intern who ended up growing into one of our great chief residents in the past, I tried to engage him in a simple, what I thought was going to be reinforcing opportunity related to diagnostic testing. And he looked at me through tired eyes and said, I don't know anything about that. Number one, it was great that he was honest. But number two, it was like, my gosh, it's also really important for those of us that have the opportunity to craft clinical learning environments to ensure that we're helping set the learner up for success. So, for example, what came out of that experience was a decision that we need to create a opportunity for our first year residents to have case-based challenges that can be answered with an evidence-based summary. And there's no pre-reading. It's all about caring for a patient's predicament and learning how to interpret what's in an evidence-based summary. It's helpful to be aware that we can't do everything at the bedside or we can't do everything within our clinical team room, but we sometimes need to think broadly so that everyone's growth trajectory remains steep.
So you've identified in what you just said challenges of time. And if I understand it correctly, you've also identified challenges in ensuring that what you put forward matches the capabilities of your learners at the particular stage they're at. Have I got that right?
Absolutely great. And most of our clinical work environments and teams are incredibly heterogeneous. And so we also have to sometimes there can be an issue that cuts across the senior resident to the first clerkship for a medical student. And sometimes it's to focus the intervention associated with a given individual or to involve others on the team, such as a more senior individual, to help explain an issue for the medical student.
Okay, you've identified a number of challenges. Any other major challenge beyond the ones you've identified so far that you see in teaching evidence-based clinical practice?
In my mind, one of the enduring challenges that exists for individuals that have some sort of an educational leadership role, be it a clerkship director, a course director, a program director for residency or fellowship, the enduring challenge that I've seen over the past 30 plus years is there can be significant excess variability that exists in what the clinical faculty are capable of doing. While that can offer richness, because then the clinical learner is exposed to a wide range of faculty approaches related to growth of skills to practice in an evidence-based fashion, there needs to be ongoing significant professional development for our clinical educators. And at these times where most of our medical centers are feeling so stressed, either because of heavy amounts of patient care volumes or limited staffing, it makes it tough. But I think it is something that's another significant challenge that if we don't address this issue, our learners are then exposed to inconsistent opportunities to see multiple rich teaching slices that can occur from a very energized and capable faculty.
When I go on the wards, and I'm obviously interested in teaching evidence-based clinical practice, And I try to throw it in and talk about evidence as we go through things. But also, typically, I'm known by the residents as an evidence-based practice guy. And I ask, okay, well, how about going through some articles and thinking about the evidence? And I have been interested and perhaps a little disappointed that sometimes they said, well, that's not how we want to spend our time. And sometimes they're enthusiastic and I'm heartened, but I've been surprised how often, they may not come right out and say it, but it's pretty clear that they're not that interested. What do you think about, as part of the picture, gauging the interest? And if not that interested, what should we do about it?
You're raising an incredibly ubiquitous opportunity for all of us whenever we're trying to do this alongside our clinical teaching. First of all, I think it is very wise for us to check the pulse of our learners. What are they interested in writ large about their clinical skill development that they'd like to improve? In other words, what areas do they want coaching on for us to help them grow related to X, Y, or Z? I oftentimes use just a simple 3x5 card that everybody gets that's brightly colored and say, I need you to jot down what are 3 or 4 areas of your clinical doctrine skills that you are interested to improve during this time. Very infrequently will it say, I really want to make sure I understand intention to treat or spectrum bias. That's not going to be on top of mind. But what it does uncover is, I'm still kind of mystified by different lung sounds, or I want to get better at delivering bad news. And so those are, or I need to understand the 47 levels of cephalosporins that now exist. Whatever their interest is, it's helpful for me to know. First of all, I've honored that I respect their needs and their aspirations. And then secondly, it gives me some insight into, okay, so this individual wants to get better related to caring for patients with end-stage liver disease. And then suddenly, whenever we are caring for a patient like that, and I like the notion that sometimes it's helpful not to say, okay, we're going to pause right now and do evidence-based clinical practice, but instead to just start approaching it by, here's the uncertainty it seems that our team has. How would we sort out what our next best step is? In other words, starting to pull them or attract them into more advanced clinical decision making that necessitates understanding what's the best available clinical research evidence related to that predicament. One way that it's fun to envision that approach, it's about stealth EBM or stealth evidence-based clinical practice. We're doing it without labeling it because it's just about taking great care of patients. And these are capabilities that we need to foster and grow during our work.
That's great. So this has been, to me, a very rich discussion about teaching evidence-based clinical practice. Before we sign off, anything else you'd like to tell us as a final message?
Goodness, that's a big open-ended opportunity for somebody from West Texas. I think one piece that is evident from the relationship that you and I have had over the past 3+ decades is it's wonderful to have individuals that are kind, generous, and help others grow, as certainly you have over the years for me. I think another piece to keep in mind is that same notion of generosity, kindness of spirit, and interest in elevating others. That's exactly what we need to bring to the table whenever we're trying to help others grow their abilities to practice in an evidence-based fashion.
Mark, I think that's a great final message. Thanks so much.
Thank you, Gore.
I'm Gordon Guyatt, and I've been speaking with Mark Wilson about teaching evidence-based clinical practice. You can find a link to the article related to this episode in the episode's description. To follow this and other JAMA Network podcasts, please visit us online at JAMAnetworkaudio.com or search for JAMA Network wherever you get your podcasts. This episode was produced by Daniel Musisi at the JAMA Network. Thanks for listening.